It's such a privilege to be a doctor, to be able to be the one that a patient confides in and trusts. It's just a tremendous privilege, and I've cherished that my whole career.
This is Daring to Tell, the podcast where writers read their true stories of personal daring and where we talk about writing and life. I'm your host, Michelle Rado.
Nothing's gonna make me brave, and nothing's gonna make me brave. Nothing's gonna make me brave except doing what makes me scared.
Happy endings. I've always said that one of the reasons I love memoir so much is for the fact that the writer has lived to tell us their story, to make sense somehow from some notable experience they felt compelled to share. Doesn't mean that it's a happy story or that the ending is what anybody wants. Nonetheless, it is how we make sense of our experiences and move forward through this thing we call life. Except, there are plenty of people who don't get the chance to tell their stories that are worth hearing and worth learning from. And that's, in part, what neurologist Carolyn Larkin Taylor has put together in her memoir and essays called Whispers of the Mind. I have always been compelled by stories about the brain and trying to understand how physiology and psychology intermingle, how much of our gray matter determines the essence of who we are, our emotions, our behavior, our decisions, and, of course, some of the strange and devastating things that can happen when that gray matter betrays us. Dr. Carolyn Larkin Taylor's book takes us inside the ERs and intensive care units and exam rooms with memorable patients in this book and shares the unique challenges of the specialty of neurology. But what is extra special about this book is that she takes us into her own world as well, with stories about when she was doing her internship while she was pregnant, of managing being a mom and a doctor, and of some rather inexplicable experiences she has had in her life, which all her training in medicine cannot really make sense of. Some of the essays in Whispers of the Mind that we don't go into in this episode include some incredible stories with her golden retriever named Prancer and the unique role she played both before and after becoming a certified pet partner in Dr. Taylor's practice. You don't have to be a dog lover to be wowed by how this dog made immeasurable contributions to the practice. Prancer is no longer with us, but Dr. Taylor now has 2 dogs, another golden named Riley and a Bernese mountain dog named Darby, who made it known that they wanted to be part of this conversation, so you'll also hear them a bit in the background as well. Finally, I think I started off our conversation with a funny opening question about a little painting that I made a long time ago, which I happened to notice was visible in my background right as she was joining. I hope I didn't throw you too much with that, Dr. Taylor. You seem to roll with it just fine. Here is my conversation with Dr. Carolyn Larkin Taylor and her new book, Whispers of the Mind, a Neurologist's Memoir. Do you see my little painting I have back there? Lobes of the brain.
Oh, yes. Wow, yeah. Have you had that all along?
Yes. So I thought, I'm going to tell the neurologist. I painted that painting.
Did you really?
And because this is not a video podcast, I will let listeners know this is a very rudimentary brain. I'm sure it's sort of cartoony, and I have different colors outlining the different lobes of the brain because back in 2012 or so, I briefly considered switching careers, and I was really interested in speech therapy. And I've always been fascinated by the brain. And so, in the course of learning, I don't, now that's a very long time ago, and I don't even remember what we were learning, but it was like, oh, if I'm going to have to learn the lobes of the brain, I could paint it and then I would know them better. And it kind of worked. Like, I remember that auditory is dealt with the temporal side on the left. I think I am correct in that
Yes.
information. All right. Um, anyways, I guess a little background just to say I've always been fascinated with the brain, which is why I am so excited to have Dr. Carolyn Larkin Taylor with me today on Daring to Tell. A big intro to say, welcome, Carolyn. Thank you. It's really exciting to have you here today.
Thank you. I'm very honored to be here and to be able to talk about the brain and how it interacts with our emotions and some of my experiences.
Yeah. I'm going to actually start with the question I often start with writers, because your book, Whispers of the Mind, a neurologist's memoir, is, I'll say, brand new.
It just came out in August, yes.
August. Congratulations.
Thank you.
No small feat ever to have a memoir come out. And what I often like talking about first is the process of writing and how you got into writing. So, what is your writing story?
Well, it's something I've always loved to do and wanted to do, but I was too busy. I was, practicing medicine full time I never really took any breaks from that. But what I did do all throughout my career was journal. And I journaled difficult situations that were difficult emotionally to handle. And I did that from the time I think I was in medical school and then all the way through residency and training and private practice. And as I got close to, well, actually I semi-retired. I was still working part-time. I was kind of reflecting on my career and I went back and looked at some of these stories. And I realized why I had journaled, why I had picked those stories. And it wasn't until I went back and looked at them, because even reading them all these years later, some of these stories make me want to just cry. And I realized that's why I had to journal them, because I had to, that was how I emotionally dealt with them.
Exactly.
I would just take them from my head and put them onto a computer or a piece of paper. Because when I started journaling, I didn't have a computer. It was many years ago. And it just helped me. It helped me deal with them. And then I could close the book on them and keep going on to another story and another story.
Mm-hmm.
But they're part of you because you lived them and you felt the pain of the families that lost loved ones or were going through something very difficult, or the pain of the patient that was getting a difficult diagnosis, and something like ALS, for instance, or heart disease, or something that they were going to have to live with for a while, and there wasn't a cure. We could do a lot to palliate or make it easier for them. But you form a relationship with some of these people because you follow them and you walk with them through their journey till the end, and they have an effect on you.
Yeah.
And some of these people were just so courageous that I just wanted to tell their story. And many of the stories that I tell, that the real heroines in the stories are the patients.
Yeah. Yeah.
What they lived with and how they dealt with it, because they were some really remarkable people.
Yeah, I felt that as well, reading through them all, the patients and their families and what people go through when they come into I'll kind of call it the sanctity of a doctor's office, to face things that they don't want to face or scared to face or don't know what's going on, maybe have avoided facing in many of the stories or many situations. Just to kind of follow up on the writing part a little bit, when you started journaling, had that been a practice for you in any of your earlier life, or did you really come into it when you started medical school or whenever it was that you started relating the stories?
It really came with medical school, because that was when I was facing really hard to deal with emotionally situations. So that's when I started it. And I went to a writing workshop that was actually out of the country, and I did it to go away. I was working on a different kind of memoir at that time because I'd wanted to write. I thought it would be fun. And when we would get together in this writing workshop, a group of us, in the evenings, we would read just some little short story or poem or something we had written that wasn't part of why we were there. And I had nothing, because I hadn't been a writer.
Oh, right.
And so I dug into my computer and I found my journal. And that's when I first opened it. And I picked out a couple of stories. One of the ones I picked out was You Can't Kill a Vet, kind of has a happy ending. Not a happy ending, a funny ending.
Mm-hmm.
First night as an intern on call on July 1st. And everybody seemed to be so enthralled with that story, throughout the telling of it, that every night they just wanted me to tell another medical story. You've got to have another one. You've got to have another one. And I was just diving through there. They weren't in literary form, but just going to see, well, I remember this one. I think you might find this one interesting. And I read them and everybody found them so interesting. That's when I got the idea, well, maybe I should abandon that other project and write down these stories because they seem to really capture the imaginations and the minds of the people that were listening to them.
That's great.
Yeah, that's when I started. And it took me a couple of years to go through everything and write them. And then I tried to write them in present tense because I thought it would make it more vivid for the person reading them as if it was actually happening. And I started working with an editor, suggested, really, I think it'll still be just as vivid if you put this in past tense, because after all, it is a memoir type of books. So there was a lot of trying to make what I had said writing it down in a book, because I'm used to writing histories and physicals for medical records and things.
Right.
So I had to try to put it really in layman's terms. That I thought I was putting it in layman's terms. I tried to imagine I was talking to a patient. How would I tell them about this? But it was a lot of great feedback. Well, if the editor couldn't understand the medical terminology, maybe I could make it a little bit easier for the layman to understand. So that's where a lot of the rewriting came in.
I see. And so when you said that about past versus present, they are in past tense, right?
They are.
Okay. I was like, wait, I read this, but then I couldn't remember. I think that's an interesting choice that I know a lot of people face is, should I write in, bring us through the immediacy of present tense versus sort of the more contemplative ability that past tense gives us. And
that was probably the hardest part, I think, for me was doing it. Because in the journal, it was all present tense because I wrote it at the time.
Right.
I had to kind of go back, and I wanted the reader to have very vivid imagery of what was going on.
Yeah.
So I didn't want to tell it so much from the past tense. And I think I kind of weaved in there what I was thinking at the time, but still tried to make it past tense. And that was the hardest part of writing this.
The fact of like translating it into past tense and almost the logistics that, I can see that, because then you're like, you have one sentence where it's somehow you missed that one and you have to go back. And a lot of these stories are personal as well, that are about you and your family, which is what makes this a different kind of memoir in essays. It's stories about patients, but it's also stories about you. And how have you found that ability or the need to switch back and forth between personal and professional through your career and your family?
It's very, very difficult, because to be good at what you do as a physician, you have to have some distance. You can't get all carried away with the drama of what's happening and the sadness of what's happening. But you also have to be compassionate and have some understanding of what they're going through. And that's one of the things you learn. It's part of the training where you learn to do that, and you see so many things and you hear so many things that are so awful, that if you want to do this job and you want to do it well, you can't fall apart. You have to just get yourself together and move on to the next case and move on to the next case. And then it was at the end of the day that I would just sometimes collapse, either in exhaustion or I've got to sit down and write this so that I can sleep and try to process it. It was my way of processing, I think. And so it's a skill that you gradually learn during medical school, because you do a lot of rotations and you're exposed to a lot for at least 2 of those 4 years of training.
Mm-hmm.
And, it's a skill that it's part of the job. We all learn to master, some better than others. Some fields are less emotional than others. For instance, dermatology,
Mm-hmm.
maybe orthopedics, but they still see, terrible things that can happen, accidents and people losing limbs. And there's still things that they have to deal with. I talk a little bit in the book about personalities in medicine that seem to go
Yeah.
into different fields.
Right.
And someone in my training, I don't want to say accused me, but he did accuse me. He just stated, because he was a surgeon, so I think he thought it was a compliment, that I had a surgeon's personality and I really should go into surgery.
Hmm.
Why was I going into neurology? But I don't at all have a surgeon's personality, but I acted like I did in that rotation because I didn't want to be there. Because
Right.
I just had a newborn baby at home and I
Yes.
really didn't
Right.
want to be there, but I
Yeah.
couldn't bring myself to leave. But the surgeon's personality is very much cut and dry. You go in, you fix it, you tell people what you're going to do, you don't take anything from anybody, and then you just go on to the next case. And these people that do surgery aren't known for hand holding. They're not known for their bedside manner typically, although I know some surgeons have a wonderful bedside manner.
Right. Right.
I don't want to disparage surgeons by any means, but
No, but I think it's interesting that there are tendencies for personalities and for why you do go into a certain specialty. And I'm wondering maybe if you can describe a little bit about the neurologist's plight, like how you came to choose that and what you wrote about the viewpoint of the people who decide to go into neurology was very interesting to me and not really what I would have guessed.
well, neurology is one of those specialties where you either love it or you hate it. And I think some of that has to do with learning neuroanatomy. It's different from the anatomy of the rest of the body, where you're thinking of all the nerve pathways as they course through the body and spinal cord and brain. You have to think of them in sections, like you're looking at an MRI in a sagittal or a coronal or an axial section where you cut in different planes because you have to follow and trace the nerves and, everything being connected. It kind of scares people away, I think. Oh, I don't want to learn that. I'll learn it for the test, but I don't want to
Hmm.
have to deal with that. And so there's the neuroanatomy part of it. But then so much of neurology still is neurodegenerative. So there are conditions that you can't cure, such as Alzheimer's or Parkinson's disease or Lou Gehrig's disease, ALS. And it's interesting to kind of make the diagnosis, but then you still have that patient. You still have to care for that patient and be with them and take care of them and try to do whatever palliative measures you can until the end. You can't just say, well, the diagnosis is made. You're on your way. I can't do any more for you. And I think that takes a certain personality, somebody that likes to get involved with their patients and likes to help them. So the person that needs to solve a problem. There's the problem solvers that I'm going to go in and solve this and then it's done. Make your diagnosis and here's your pill or the surgery that's going to fix you. Those people would be very unsatisfied in something like neurology because often there aren't any answers.
Yeah.
And there's the mystery of it. There's the neurology and your emotions and everything kind of interweave that it's fun. It's almost like being a Sherlock Holmes. So people that like mysteries, people that like puzzles and like, the arduous process of sorting things out and figuring them out are going to be attracted to something like neurology.
Yeah, I found that part to be very interesting. And that, yes, you would need to be able to have that desire to keep working through complicated symptoms or not necessarily satisfying solutions. And that it was not seen as a specialist that most people liked for a lot of reasons. So I don't know. I found that interesting. I never even would have thought about the neurological pathways and like how you were just describing about how you look at them in different planes. As just a lay person, I would say they seem mysterious or ethereal to me as like, okay, I feel things. I know I have nerves running in pathways, but when you have surgery and they get cut and something doesn't grow back the right way, or like they're not as concrete to me anatomically, I would say, as bones and veins and those kinds of things. So I see what you're saying about that.
Yeah. And at the time I went into neurology, there was so much less we could do for people with neurologic disorders than we can today.
Yeah.
We've come a long way with various treatment options and discoveries, genetic discoveries of what causes certain diseases and how you can treat them. And there was a saying I remember when I was a medical intern, and we all kind of knew what each other was going to be going into after internship. And it was actually a first year of an internal medicine residency that I took. It wasn't a rotating internship into all different fields. It was internal medicine that I did for a year. But there was a saying like, why should we bother to consult a neurologist on this case? Because all they do is offer aspirin or steroids. There's nothing else they can do. We might as
Mm.
well figure it out ourselves. And
Wow.
that was just kind of a joke. Um, but the reason that I remember as the intern, the medical intern, as we had cases on the wards when we would consult neurology before I went into my specialty, even though I was already committed to it, was they were just so contemplative. They would come in as a team and they'd talk about the case and they'd think about it and they'd be very thoughtful and they'd kind of put another spin on things that we hadn't thought about. And they were also very useful when somebody was dying and there was also a brain injury involved to
Yeah.
get that prognosis. What kind of neurologic recovery can this person expect after this type of injury? Should we keep pursuing hemodialysis or take them to surgery or, keep coding them if their heart stops? Because is there enough brain function left that it's worthwhile to do this? Because to go through all of that you might have to go through to keep someone alive that may have had a devastating injury or in multi-system organ failure, if the brain itself is damaged, you do all of that, and then what is left? Why did you do it? And so they often would bring the neurologist in to help with prognosis. That helps the family, saying this is
Yeah.
probably as best we know what you can expect your loved one to be like a year from now, their capabilities. Maybe they won't understand or they won't be able to talk. Maybe they'll be in a vegetative state, so we're just keeping their body alive, but there's going to be nothing there. And that was always a very useful thing. A sad thing,
Right.
not always bad. Sometimes we could give a good prognosis. And I was drawn to that kind of thinking process and
Yeah.
being able to add that kind of dimension to a whole picture.
One of my really specific questions about a scenario like that you were just describing, when I think that the question most of us have when we think about what if something happens to me or my loved one and what that potential recovery is and who are they going to still be and will they be able to still be themselves somehow? When that answer is not the direction that we want it to go, you've talked about being with the patient, walking through their prognosis or with them or their family. And what does that look like from your chair, as how to talk with people about these really difficult things as they're going through either, ALS or other diagnoses that don't have a good prognosis?
Well, it depends on how emergent the situation is. So, for instance, if you think someone could have a brain tumor that could be treated, you're in more of a hurry to get that diagnosis and get them into the right place
Mm.
with oncology, maybe refer them for a brain biopsy early. Whereas if you're dealing with someone that you're fairly certain this case is going to be ALS, which is a neurodegenerative condition that predominantly involves the spinal cord, some brainstem, that there is no cure for, and it's slow and progressive. Death usually ensues within 5 to 6 years of diagnosis. So you have a little time. And you're going to have to tell the patient what's going on, but that there's a couple of rare other things this could be, and you want to absolutely exclude those before you give the diagnosis. So you kind of set them up for, well, there's a couple of possibilities and we want to do some additional tests. And so at that moment, there are some people that are more medically sophisticated than others, and they may have read up on this, and they may have had a pretty good idea when they walked into your office that this could be ALS. They may have known someone, for instance, that had it, or they got on the internet and Googled fasciculations or little twitches in the muscle, and that scared them enough to get them in to see you. And so sometimes they will start asking questions, and very pointed questions, and could this possibly be this? And so in my experience, you just have to be very honest with them.
Yeah.
They understand enough to ask those questions. They're ready to hear it. And you try to tell them, yes, that is a possibility, and this is why, but there's also a small possibility it could be something else. So we just want to be absolutely sure. There are those people that are pretty medically sophisticated. I talked about one in a chapter I did on ALS. It's called Difficult Conversations. And I could tell they postponed coming in. They had decided on their own that this was probably a stroke and that they were just going to get better. And if they postponed coming in, they'd probably be better by the time they came in, but they weren't, they were worse. And so everything in their demeanor told me they have an idea this is ALS, but they never mentioned it.
Mm-hmm.
Very happy to hear I was going to do an MRI and get some additional tests and get some nerve studies done. And with each visit, to tell them the results of the tests, which the whole process took maybe a couple of weeks, I finally said, we've eliminated a few things. Have you been reading up on this? Is there something that you're afraid of? And then they came out with it. And then that kind of opens up the conversation.
Yeah.
So you just have to feel the patient out. When they're ready to hear it, they'll let you know. And sometimes they're never ready, but you have to let them know at some point.
What do you do then?
You just have to. You have to just tell.
Like again and again.
You have to tell them. What I usually try to do is get them to bring a family member in with them, or a close friend if they don't have a family member. Sometimes they want to shield the family member. They know something serious is wrong and they don't want to, they're worried about their family. I want them to bring a friend. I want them to bring somebody that's going to really hear what I say. Because once you start that conversation and you say the name of the disease, I think they turn off and they don't hear anything else because they're in such shock or they're just so devastated that you try then to talk about what we can do and what research is being done and how we're going to approach it. But they don't, you can see in the look in their eyes.
I was going to say, how you must be able to tell just looking at them. I'm sorry, go ahead. Yeah.
And so you try to get that other person there that's really going to listen, that can reinforce that conversation with that person later on that day or the next day. Some people want to record what you say, but usually not at that visit. They're too upset. Later on they will. Or when I broach the conversation and they're one of those people that refuse to bring someone in with them, then they'll say, can I call my daughter? I want to put her on speakerphone so she can hear this too. So of course you allow that. Yeah. The more interaction you get and the more assistance you can get from family is very, very helpful.
Right.
The hardest one is when there is nobody and you're just dealing, or they don't want that kind of personality. They want to be stoic and do it all themselves and not tell anyone for a while. Those, you have to deal with them very carefully because it's more than most people can handle alone.
What do you do when you go home at the end of the day after dealing with someone like that? I mean, that's got to be incredibly difficult on your behalf. I mean, I'm guessing that coming to the journaling is part of it, but what is that part like for you?
Well, over the years, you get used to it. And I used to bring everything home. So I'd bring everything home with me and I'd think about it, or I'd talk to my husband about it, or my dog who couldn't tell anybody, or I'd just discuss a case, or I had this good friend that's a geriatric psychiatrist
Mm.
that also dealt with some of these kind of cases. And I would, give her a call. And as the years went on and you just did this more and more, you'd feel very badly, but you would learn to leave the problems at the office.
Mhm.
You'd close that chart, you'd finish your dictations, and you'd walk out and you just tell yourself, this is my private time with my family now, and I'm not going to bring it home. Otherwise, you just would go crazy.
Yeah.
And I used to, use that drive. When I would drive, I would think about it and contemplate
Oh, yeah.
everything that went on in the day. And sometimes I'd miss my exit because I would be thinking about it, the conversation. I'd have to turn around and go back.
Oh, man.
And then once you parked the car and walked into your house, at that point, I'd say, okay, it's done. I'm leaving it there.
Yeah.
And I found that my relationships with my husband and of course, it's not something I would burden a child with, became much better when neither of us brought our day home.
Mm.
That
Right.
takes years to learn how to
Yeah.
effectively.
Yeah. Well, another thing you talk about through all the stories that you write and some of the personal ones as well is an intuitive sense that you develop over time. And I don't know, I just appreciate hearing that as a doctor, you have to really tap into your intuition about not only your patients, but it sounds like going home at the end of the day too.
Yeah. And I think many people that are capable of empathy have this. They don't always fine tune it because they're not in that kind of field where they have to. But when a patient comes to see us as a neurologist, often an initial evaluation is an hour because we deal with some complex cases, and taking that history and doing the physical can take a long time. And so they don't always come to you about what's really bothering them. They might be coming to you about headaches or tingling sensations, or they feel like they're off balance or they're dizzy. But that might be something else that they're worried about that they think is neurologic that they're not saying. And so you have to, during your visit, you try to get in touch with how is that patient making you feel.
Yeah.
So you might be feeling very good as you walk in the room, and when you walk out, you're depressed.
Mm.
It's not that they said anything depressing, but that patient was depressed, and they made you feel that. You actually feel what the patient is feeling.
Yeah.
So it's an intuitive kind of thing. And, it's hard to describe what is intuition. It's just kind of
Yeah, exactly. I ask these questions that often don't have answers.
it's kind of just a knowing. I talk about in Every Day Above Ground is a Good Day. And someone reading that story, I had this apparition of my mother dying and exactly how she was going to die. And it was fleeting, just in my mind's eye, just boom. And then it was gone. I'd never had anything like that in my life before. It wasn't a dream. I didn't know what it was. And I blew it off.
I wonder if I might stop you there, because this is one of the stories I was going to have you read. So maybe we should just have you read it. What do you think?
Sure.
Okay. I don't want to give away too much. Okay. So this is one of those that is a personal story about you and your mom, in addition to your practice as a neurologist. So whenever you're ready.
Okay. And I've dedicated this book to my mother, who is the smartest, funniest, most courageous woman I've ever known. And I was so lucky to have her in my life. And I hope I can get through this story without crying. So 3 weeks into my neurology residency, something happened. And I have a couple of personal stories in this book that have to do with my life, because it is a memoir of medical stories, but a memoir of my life as I dealt with these stories. And the stories I included in here all have to do with neurology. So I thought that they would be appropriate. So this is called Every Day Above Ground is a Good Day. The day began like any other, with my alarm ringing at 5 a.m. I hoped my early start would give me a few precious moments with my young son before heading to the hospital. Summer traffic into Philadelphia was often lighter, with schools out and families on vacation, so I could make the drive in under 40 minutes. Those early morning drives had become a rare moment of calm, a quiet space to gather my thoughts before the chaos of the day began. After surviving the grueling first year of my medical internship, I had finally stepped into my neurology residency, a new chapter full of challenges, but one I was eager to face. The drive to the hospital that morning was uneventful. Reaching the parking garage with 5 minutes to spare, I drove to the very top of the garage, giving me further to walk, probably my only exercise for the day. As I exited the garage, I could see the stately hospital just across the street, beckoning me in, surrounded by historic Philadelphia's cobblestone streets and their street lamps in the style of colonial-era gaslights. The rising sun was almost blinding, the light filtered by the trees swaying in the crisp early morning air. At that moment, an image I had never seen before suddenly sprang vividly into my mind's eye, unbidden. That of my own mother, her face pale and lifeless, in an ICU, on a ventilator, with tubes and IV bags everywhere. The head of her bed was tilted in a downward Trendelenburg position, as in cases of hypotension and shock. Somehow, I knew at that moment that she was dying, and the phrase atrial fibrillation, an irregular heart rhythm associated with a high risk of stroke, sounded in my mind. The image was so vivid it jolted me, but just as quickly as it came, it was gone. I shook it off. My mother had been perfectly fine the week before, laughing and full of life. There was no reason to think something was wrong. Seconds later, as if it never happened, I found myself crossing the street, about to walk through the hospital's heavy glass entry doors. I felt certain the image was just due to an overactive imagination. After all, I had just started my neurology residency. Having spent the last few weeks managing stroke cases in the ICU, atrial fibrillation requiring anticoagulation, blood thinners, had been a common complication. Atrial fibrillation is an irregular, often rapid heart rhythm that can potentiate the formation of blood clots in the heart, which can then embolize to the brain. The stroke risk associated with this is often treated with blood thinners to prevent the blood clots from forming. I was struggling to learn as much as I could, as fast as I could, to care for these patients, having been a neurology resident for only 3 weeks. Little did I know that brief, haunting glimpse would become a chilling reality. The days and nights went by quickly, filled with learning as I worked under the guidance of senior residents and neurology attending staff. The on-call experience was particularly challenging, as it was just me responsible for those very sick patients during the middle of the night. The mere thought of being the only neurologist in the hospital at night, having only been practicing neurology for a few weeks, was something I dared not even contemplate when I received that call to come to the ER for a consult. Just a few short weeks into my first year, there I was, being called to the neuro ICU, with a patient crashing, with elevated intracranial pressure, or a cerebral bleed, and me with only my little black book of neurology pocket guide to help me. There were times during these hectic days when the patients all seemed to blur together. Cerebral hemorrhages, status epilepticus, unstable elevated intracranial pressure, strokes, and more strokes, all lying there, attached to various forms of life support. My neurology backup attending was at home, snugly tucked into his bed, and I would do almost anything to avoid waking him. The neuro ICU was filled with people, ordinary people, someone's parent, someone's child, someone's spouse, just like you and me. But I rarely got to meet them before their event, so by the time I arrived on the scene, they were already sedated and had tubes and machines everywhere. I only got to humanize them later through the stories or loved ones would tell me. I spent my time following their numbers, vital signs, input and output, ICP, intracranial pressure, ventilator readings, etc. I had been trained to be objective, to distance myself from their pain, so that I could be decisive and treat their disease, and so that after a failed code, I would be able to walk down the hall and start all over again, objectively assessing the next patient, the next stroke, the next seizure. I felt like I was beginning to master that ability, but I was still struggling to master the art and science of the neurology itself. But what exactly was that ICU vision of my mother I had experienced that morning? A hallucination? A daydream? A thought? Just my overactive imagination with intruding images derived from a compilation of the many images I saw daily, especially rounding in the ICU? It seemed like a glimpse of a dream, but I was most definitely awake. I had seen so many similar images over the past several weeks in real life, one patient after another in the ICU, on ventilators, sedated, and attached to tubes and IVs, each critically ill, and many with a prognosis poorer than the last. I'd seen my mother just a few weeks earlier, during the transition week between my internship and residency. I had taken a brief trip to the beach at Cape May with my husband and son, and she drove down for an afternoon to spend time with us. She was fine. She is fine. Time spent with family during medical training was precious, and we all enjoyed a wonderful week together. Putting the image out of my mind, I entered the main lobby and made my way to meet my senior resident to get my assignments for the day. It was always a good day when I wasn't on call, or when I had completed call for the day and was free to enjoy an evening with my family. Forgetting all about my disturbing premonition that morning, I was talking about the events of the day with my husband when the phone rang. It was my sister Judy. Mom was just admitted to the hospital with an upper respiratory infection and difficulty breathing, she said. They had to put her on a ventilator, but they expect she'll be better in a few days on antibiotics, so no need to worry. Suddenly, my apparition came flooding back to me now. Did they say anything about atrial fibrillation? I asked. Oh yeah, forgot to tell you that part. My mother's hospital was 80 miles away, and after calling the hospital, I was assured she was stable for the evening. I was on call the following night, which meant I would be working at my hospital for the next 36 hours. Thoughts of my mother intruded into my concentration throughout that long shift. There's no reason for alarm. She has not had a heart attack or a stroke. She's only on a ventilator because of an upper respiratory infection that probably triggered the irregular cardiac rhythm. And she should already be improving by the time I get there. When my 36-hour shift finally ended, exhausted, I raced to the community hospital at the Jersey Shore, where my mother had been admitted. This wasn't the kind of ICU I was accustomed to at my large academic institution. There were only 4 beds, separated by white curtains, instead of glass doors. But the combination of the sounds of the ventilators and heart monitors and the antiseptic smell were unmistakable. I was relieved to find my mother awake and sitting up in bed. Her crystal blue eyes, the same eyes that could always see right into my soul, trying to console me. Her wonderful dry sense of humor was on full display on the sign she had the nurses put above her bed. Every day above ground is a good day. Despite adequate treatment of her lung infection with antibiotics, the doctors were having a difficult time getting her off the ventilator because of her chronic pulmonary disease from her history of smoking. They had also started her on IV heparin to thin her blood as a preventative measure for stroke because of her new atrial fibrillation that had the potential to form blood clots in the heart. Communicating to me through handwriting, she related that both the pulmonologist and cardiologist were on her case, and she complained to me about abdominal pain. I asked if she had let her doctors know. She confirmed that she had. Before leaving, I inquired about this with the nurse at the desk, but the doctors had left for the day. She kindly placed a call to the pulmonologist so I could speak with him. He said he was aware of her complaint and thought her pain was just from coughing from the ventilator, but he promised to call a surgical consult that evening to have it checked out further. Tired but reassured, I drove home and crawled into bed, only to have to get up 3 hours later to go back to work. It was going to be a very long day. My mother looked good and was in good spirits. She was going to be all right. I had 20 inpatients to round on, some in the ICU, and the floor consults were already starting to come in. My pager was going off constantly, each call taking me in a different direction, to a different crisis, or just to talk to a worried family member again. It felt good to be busy and productive, so I had less time to be distracted and to worry. Then came the call. It was 10 a.m., and my mother had been found unconscious that morning, having bled out 9 pints of blood into her abdominal cavity overnight. Her heparin level had been critically elevated the day before and never adjusted. Her abdominal pain had been from the bleeding, which was completely missed by her pulmonary attending and the surgical consultant who came in the evening before. He had just given her morphine without ordering any further diagnostic studies, failing to notice her critical heparin level, which had been missed earlier. The sedation from the morphine further contributed to the delay in discovering the bleeding. I knew at that paralyzing moment that I would never speak with my mother again, that she had already crossed a threshold that meant she was incapable of meaningful neurological recovery. How many times I've used that phrase over the years, and how many times I've witnessed the look of terror and loss in the faces of my patients' loved ones. I raced to her hospital, begging and pleading with God to somehow spare her. It was not yet her time. She would never get to see her grandson grow up, and Rory would not have the delight in knowing her. And what about all her other grandchildren and family memories yet to be created? She had worked so hard her whole life, raising 4 children all by herself. This was supposed to be her time to enjoy her family. And what about me? I wasn't ready to lose her. When I arrived, there was the unmistakable foul smell of melena, black tarry stool from gastrointestinal bleeding, filling the air. Her bed was in Trendelenburg, and there were numerous IVs infusing blood pressure pressors and blood. She was dying, and the image was exactly as I had seen it that morning 3 days before in the rising sunlight. She never regained consciousness. She lost oxygen to her brain and her kidneys from critical loss of blood. For the next 5 days, my mother remained in that state, occupying the corner room in the ICU, surrounded by starch white curtains, the light from a small window across the hall illuminating the pallor of her skin. Her 4 children kept constant vigil by her bedside, as we didn't want her to die alone. Late one evening, I had just stolen a few hours at home to see my little boy when the call came. It was Judy. Mom's heart just stopped, and she's been pronounced dead. The doctors want to know if you would like them to keep her body in the ICU to say goodbye before sending her to the morgue. Yes, I said, I'm leaving right now. Please keep her where she is. I raced back to the hospital, and upon arrival, I was surprised to see my 3 siblings still standing around her bed. As I approached, I could hear the whoosh, click of the respirator and the undeniable heartbeat from the monitor. I don't understand, I said. I thought you said her heart had stopped. The most unbelievable thing happened when I returned from making the call to you, Judy replied. Mom's heart just started up again. It's slow, but she's not dead. For the next few hours, we all stood around her bed, recalling wonderful stories, funny stories, mostly about her sense of humor. As the sun started to rise, casting a beautiful orange and pink glow on her bed, her heart stopped for the 2nd time, this time the last. I have since imagined my mother's spirit hovering over her bed that night, listening to my call announcing I was on my way, and waiting for me so she could spend a few more moments alone with all her children together. She would have loved that. My mother died on Thursday. We had a funeral for her Saturday. I returned to my resident duties on call at the hospital on Sunday. I was unable to make it through that first day, collapsing in tears in the restroom. I was sobbing so hard that I couldn't even manage to answer my pager. A very kind neurosurgical resident, who had been looking for me to sign out his patients, found me there and sent me home for the rest of the day. For months afterwards, I struggled to get through my days. I dutifully showed up, took all my overnight calls, but my heart was not in it anymore. Losing my mother so early in my career shattered my sense of objectivity as a physician. Her death, which could have been prevented, left me questioning everything, my choice of specialty, my future in medicine. For nearly a year, I struggled, tempted to walk away from neurology and from medicine entirely. But slowly, as I worked through my grief, I found my way back. In time, I regained the ability to care for patients with clarity, though my compassion had deepened in ways I hadn't expected. If there's one thing I took from that painful experience, it's the power of intuition. It has become my greatest ally in medicine, a gift I've learned to trust and respect. And through it all, I carry my mother's memory with me, not just for her strength and courage, but for her ability to laugh, even in the darkest moments. It's that spirit I hold on to and that keeps me going.
Thank you so much for reading that.
Oh, you're welcome. I
Oh,
got
what a
through.
yes,
Yes,
yes. I mean, I think that when we have those tears when we read, it's the heart is in the words, and reading it
yeah.
brings it back all over again.
It brings back those feelings all over again. It does. And it's interesting. My mother, in her life, had a couple of apparitions like that.
Really?
Yeah, and she used to tell this story, and I believed her, of course, but when I experienced it myself that one time, I understood. She saw, she was reading a newspaper, and my oldest brother, who was about 7 years old then, was outside in the yard sledding. It had snowed. And in her mind's eye, she saw him go into the street and get hit by a car. And it was vivid and there and gone, and it frightened her, and she jumped up and ran out the house. And at that moment, after she ran out, she saw his sled go into the front of the street, and he got run over by a car. So she saw it before it happened. He was okay. It was a broken leg.
Oh,
And then she had another apparition in her life when her mother had visited her from Manhattan to New Jersey and took a train. And the train station wasn't that far from her house. And she left to get the early evening train back to Manhattan. And my mother was at home. I don't know what she was doing, but she suddenly had this apparition of her mother falling on the train track as the train was coming. And it startled her so much. It was because it was so vivid, just like she'd seen my brother get hit by the car. And she was paralyzed. She just didn't know what to do. And then she heard the horn of the train. And then she heard the train pull off again. So she knew, well, nothing could have happened. If they had run over someone, the train would have stopped. There would have been ambulance. And she just blew it off. It's nothing. It's nothing. I'm just, my overactive imagination. And when my grandmother got back to Manhattan, she called my mother and said, the strangest thing happened. I was crossing the train track because I was late, and I tripped and fell, and I got up just in time to get to the other side and make my train without my mother even having to ask her. So when I had that apparition, I didn't think of my mother's two events because I was busy.
right.
I just couldn't believe it. That just was, I had a million other reasons why that had happened to me. But in hindsight, I recall those two episodes my mother had. And I think it's a connection, a deep connection we have with a loved one, a
Yeah.
parent, a child,
Hmm.
that we're capable of that.
Yeah. I was going to say, as a doctor and especially a neurologist, like, what do you make of that?
I don't know what to make of it. I
Yeah.
don't know what to make of it. It's intuition, but it's almost as if there's another realm where time doesn't exist, and it suddenly intrudes on this realm, and you see things or you have a dream about something that's going to happen, and then it happens. I mean, I don't know that I have an explanation for it.
Right.
And
Right.
it's not something that's ever happened to me again quite like that. So I think it's this deep connection with a loved one. And I think it's whether it can happen with a spouse that you love or there has to be a genetic connection. Who knows?
Yeah.
Who knows?
I was going to say, I mean, connections between mothers and children, there's like cells that are common. Am I right about that?
Yes, that still live inside of you. And I have that deep connection with my son. I only have one child, but I have that kind of connection. That's a whole nother story. And it's kind of eerie. I feel good about him if I'm not thinking about him. If I
Hmm.
have a dream or something about him, I have to call him right away. I say, I'm worried
Yeah.
about you. I just need to hear your voice because I had this odd dream. But generally speaking, I don't have those. So
Right.
I feel like everything's okay. But
Yeah.
you hear that from a lot of people, I'm sure.
Yeah. Yes.
The
That there's
feeling.
something. Yeah.
Yeah.
I do like how it ties into that thing that we discussed about intuition, that it helps you just think or feel differently about your patients, and still retain the ability to be empathetic and yet maintain enough distance to move on to the next person. Yeah. I'm just kind of absorbing all that because those are things I think about a lot in
Yeah,
terms of, what happens to all of us when we go to the doctor or do whatever we do in our lives. And it's moving to hear it from your side of the stethoscope or whatever you want to call it.
reflex
Yeah.
hammer.
Yes.
Yeah, yeah. It's a such a privilege to be a doctor, to be able to be the one that a patient confides in and trusts. And
Yeah.
it's just a tremendous, tremendous privilege. And I've cherished that my whole career.
I am hoping we might have time for one more story. I know I call them stories, one more essay. There are so many, and I feel like we could have an in-depth discussion about each one of them. Many of them are, as we talked about before, serious and devastating, and what it takes to walk alongside a patient with in those kinds of circumstances. I don't want to tip my hand too much, but this might have a slightly different ending, but also equally fascinating, is what I think. The one that is called Grief Waits, if you'd like to read that.
Yes, yes, I would love to. Grief is like a shadow that lingers at the edge of the soul, an unwelcome guest that arrives without warning and refuses to leave. It is a heavy cloak draped over the heart, pressing down with a weight that seems at times unbearable. In the quiet hours of the night, it whispers like the wind, reminding one of loss and absence. One of the things I loved about the practice of neurology was a challenge of diagnosis. Neurologists are often referred those patients with a myriad of complex symptoms no other specialty could quite sort out. We frequently became the last resort, so to speak. I often thought that was because, by the nature of our chosen field, we were somehow more thoughtful and contemplative. My best teachers in the field taught me that the answer was most often found in the history. Listen to your patient carefully. Never rush them, for they will often give you the answer you are seeking before you even examine them or perform any tests. If you have listened well, your examination and testing merely confirm the diagnosis for you. I took this to heart as their words flooded back to me in some of my most difficult cases. Martha was a 60-year-old woman referred to our neurology residency specialty clinic for evaluation and management of advanced dementia, such that she had become unable to function on her own. She was accompanied by an entourage of concerned family, her husband, son, and 2 daughters. Her husband, a balding older man with kind eyes, began by saying, "We've been everywhere, had every test, and still no one has been able to help us. We've been told she has an atypical form of dementia, which is progressive and untreatable. We just can't give up on her yet. Can you please try to help us?" I hated to discourage them, and I certainly didn't want to give up on her, but I had reviewed all of Martha's records. Her testing had been very extensive, and yes, inconclusive. What could I possibly have to offer her? I began with another detailed history. Martha's daughter, a middle-aged, athletic-looking woman, spoke next. "We've told every doctor all of this before," she said. "Can't you just look at her records?" "Yes," I responded, "but it would be helpful to me if you would tell me yourselves, and please don't spare any detail." Martha's husband and 3 grown children all contributed to describing their mother before she began to show signs of dementia. Martha was extremely functional prior to becoming sick 2 years earlier. The mother of 6 children, she managed the busy household, and in her spare time worked as a bookkeeper for her husband's store. She was engaging, humorous, intelligent, and meticulous. She never made a mistake with the books, and the household ran flawlessly. There was no family history of neurodegenerative disease. It all seemed to happen quite suddenly, although they all admittedly went about their busy lives and didn't even notice the subtle signs earlier on. Then one day, Martha failed to get up early as usual. When someone finally roused her, She wandered aimlessly into the kitchen and wasn't able to figure out how to open the refrigerator or how to start the microwave. Then she picked up something to read, and they realized it was upside down. She deteriorated from there until she was unable to even care for herself. When she talked, she appeared confused, and over time, she became less and less verbal. She now spent most of her days sitting in a chair, staring out the window, often failing to even dress for the day. She had multiple brain MRIs, EEGs to evaluate for the possibility of seizures, vials and vials of blood work, and a spinal tap to no avail. As I stood looking at her, Martha appeared to be older than her stated age, with deep facial lines and gray hair tied neatly in a bun, dressed in a house dress that was too large for her. She just sat there, despondent, looking blankly at me when I addressed her, completely mute. She didn't follow complex commands, but inconsistently she would follow a simple command, such as close your eyes. Her neuroexam was otherwise nonspecific, with normal strength, sensation, and reflexes. Her gait and coordination were also normal. If I hadn't seen the normal MRIs, I would have suspected a frontotemporal form of dementia that can lead to mutism, but there was no predictable atrophy in the frontal or temporal lobes. Finally, I asked about a history of depression in Martha, or anyone else in the family, and they all denied this. Her son, a middle-aged, well-dressed businessman, addressed this issue best. Mom was always the upbeat one, he said, the one that kept us all together and cheered us on when we had problems. I just knew I was missing something important here, but what? Tell me again how this started, I said. Was there anything else going on at the time that might have precipitated this? They all looked at each other quizzically. Not really, the son said. Dad had just retired. It's a good thing, too, because he's around now to help with Tommy. My ears perked up. Who is Tommy? And why did your dad have to help him? Tommy's our oldest brother. He was in a devastating motorcycle accident when he was just 20 that left him quadriplegic from the neck down. Mom refused to put him in a care facility and had been his sole caretaker, bathing him, feeding him, and being his source of emotional support ever since. Tommy is still at home with Dad, so you can see how difficult it is for him, as he now has to take care of both of them, Mom and Tommy. Could it be? Could this woman have been so needed by her son and everyone else that she couldn't stop to take the time to grieve what she had lost, what her oldest son, whom she loved so dearly, had lost? The enormity of that task, of being his sole caretaker, not just for his physical needs, but for his emotional needs as well, was beyond my comprehension as a mother of a son myself. Not only that, but she kept everyone else in the household going. That is, until the day her husband finally retired, and she knew she could safely turn that task over to someone else she trusted. Pseudodementia is a shadow that mimics true dementia, clouding cognition and memory while concealing a different pain beneath. It's like a heavy cloud of depression, casting a cold, dull light over the world, turning its vibrant colors into muted grays. The heart feels this weight, but the cause remains hidden, masked by the signs of cognitive decline. Yet unlike true dementia, the core of the self is still intact, buried beneath layers of sadness and exhaustion. The mind feels wrapped in darkness, waiting for the clarity of understanding and treatment to break through. There is hope, for pseudodementia is not a permanent loss, but a temporary and difficult detour. Martha had instinctively postponed her grief-induced major depression, the cause of a pseudodementia, for all those years because she felt she had to. Now recognized, I referred her to psychiatry, and she underwent aggressive inpatient treatment with therapy and medication. Incredibly, she was back to her former self within 6 months, the treasured heart of the family. Grief is a process that cannot be avoided. In the world of grief, time moves differently. Days stretch into eternity, and moments of joy are fleeting and rare. The past is a vivid tapestry of memories, while the future appears as a distant, unreachable land. The present is a slow march through a fog of pain, where every breath is heavy with the effort of simply continuing. Yet within the depths of grief, there is always a profound connection to the very meaning of love. It is a price paid for the gift of loving deeply. Though it may never fully disappear, grief evolves, occupying a smaller corner of the heart, a reminder of the way things were and the resilience of the human spirit. This story teaches us that no one can escape the eventual showdown with grief, no matter how long they manage to postpone the meeting. He demands your full attention before you can heal, and he will wait as long as necessary for you to look him straight in the eye.
Wow.
Yeah,
That gives me chills just as you finish that up. I mean,
a happier ending, though.
yeah. I
Yeah,
mean, lovely to have a happy ending. So many are not, you know. So and I gravitate towards the happy endings. But out of many things in this story, I guess the top line for me of most remarkable or notable was your perseverance to try and listen more deeply to what the story was. Because if you had not done that, you wouldn't have been like, wait a minute, who's Tommy? You know, what's going on with this? And relating to patients in many ways, I go, oh my God, how many times do I have to tell the same story over and over again of how this thing happened to me? And there's a lot of frustration about repeating our stories, you know, to this person who comes in and the next person that comes in. But sometimes there is that little something that just
you just
helps
have to,
you clue in.
right. That's what it's kind of like being a Sherlock Holmes, just trying
Yeah,
to listen differently and get a different take on it. And I think I kept pursuing it because nothing made sense. You know, her MRI was normal and everything was atypical about it. It wasn't vascular. It didn't look like Alzheimer's. There was no family history of neurodegenerative disease. And after all this time, we should see atrophy or something on the brain evolving. That I kept pressing this. And naturally, they had told this story so many times, they were tired of it. And it was hard to put it together because the event had happened years ago.
right.
But there's something about our defense mechanisms. If you have to do something, you have to get through something,
Yeah,
you postpone that appointment with grief because you can't break down or this critical place that you're needed. Her son needed her. And if she broke down and grieved, who was going to take care of him?
right, right.
And really, she didn't trust anybody else to take care of
Yeah,
him the way a
yeah,
mother would. So she
yeah.
had to keep going until it's like a circuit breaker.
Mm,
You know, you can just take that overload so long and then that circuit breaks and everything just stops.
yeah. Wow. Had you known about pseudodementia? I mean,
Oh, yes.
you must have. So you knew about that and you were like, oh,
You always look for something that's treatable. And that's one form of dementia that is
wow.
treatable.
Yeah.
Yeah.
Um, my other question about that is the overlap, I think, with something that seems like this pseudo dementia of it being a physiological, neurological problem versus a psychological problem, and how those two can sort of become intermingled, trying to tease those things apart. Because I think of grief as you're sad. I mean, you beautifully articulate it about it being connected to love. I mean, that's what it's grief is the loss of love. And so there's sadness with it, but that sadness, as you say, can sort of build and become a physiological problem.
It does. It's, our mind and body are so connected that things we don't process can turn into chronic pain. They can turn into any number of the conversion disorders where people can be paralyzed or seem to be paralyzed, but they're not really. People can become mute and they can't talk. They can't see, hysterical blindness.
Mm.
Hysterical is one word for it, but it's a conversion disorder. It's not in the patient's consciousness to control.
Right.
Um, there's a condition called non-epileptic seizures, or an older term used to be pseudo seizures, like we use the term pseudo dementia.
Mm-hmm.
That it's that circuit breaker that just flips. The human psyche just can't handle any more emotional pain. And it's a switch that flips and the pain goes somewhere else because you can't deal on a conscious level. So we have our consciousness and our conscious and our subconscious.
Yeah.
Some things get reverted to the subconscious, and we aren't aware of why we're doing something or why it's happening to us.
Mm.
But there is that tremendous need for survival, and more than survival, there's that need to help someone else that needs us to survive. The parent that gets through enormous difficulty and danger to save the baby or save their child. People can do extraordinary things because they have to be the one to be there. And then when that task is over, they can finally collapse and deal with what they have to deal with. But
Yeah.
those parts of the brain are intimately connected. And these are all a form of trauma, like the patient with PTSD that forgets some things because the part of the brain that deals with those strong emotions is also connected to the hippocampus, the part of the brain that has to do with recall and memory. And so those parts of the brain are all connected, and they are responsible for these phenomena that we see that are protective mechanisms, so to speak.
Mm.
But in order to cure the problem, whether it's the pseudo seizures or the dementia or whatever the chronic pain, you have to bring that trauma from the subconscious up to the conscious so that you can consciously then process it and deal with it. And that's the only way to make those things get better. And that's why psychiatry and neurology are intimately connected.
Yeah. Yeah. It was a fascinating and astute example of that with the grief
Yes.
story.
Yes.
And conversion, what do you mean by conversion disorder? Like the conversion from neuro to psycho? Is that
Yes. Yes. Somebody
okay?
puts psychiatric or emotional symptoms into physical symptoms, and we call that a conversion disorder. Someone that presents with epilepsy and seizures, but it's emotional. They're not. You put an EEG, record an EEG, which is electrodes on the head that record their brain waves. The same time they're having one of these emotional seizures, their brain waves are normal. You don't see
Wow.
the electrical discharges of a seizure.
One of the other things that you write about and advocate about is when I think about that in terms, as you describe these conversion disorders, is gaslighting and like, oh, the patient, this is just often her fault. She's doing something wrong or she's not, we don't believe her. So that's another powerful thing that you bring out through your essays.
Yeah, it's a very real phenomenon, medical gaslighting. And it's not always malicious.
Right.
It's
Thank you for saying that. Yeah.
it can be by a very well-meaning provider that does this. They've seen so many, perhaps more women than anything else, complaining about maybe chronic pain or some other thing, and they tend to, it might be someone that's very stressed or is dealing with stressful events in their life, and they just kind of write it off. Oh, you're just stressed. There isn't anything physical
Yeah.
wrong with you.
Right.
And there may not be, but and oftentimes there is an underlying physical thing going on. And maybe they are elaborating on it a little bit more because of other things. But you always have to be sure there isn't anything physical. And even if it isn't purely physical, they still have this problem.
Right.
They still have the seizures or the chronic pain, and
Yeah.
someone needs to help them to get to the bottom of it so that they can get better.
Yeah.
And so that's where we don't do psychiatric therapy with these patients, but we have to be able to recognize it. As neurologists, we have to be able to determine that there isn't an underlying neurologic problem, and then get them in the right hands of a good therapist that has experience in treating such things. And they're not that easy to find. They really
Really?
aren't. Yeah.
Yeah. What was your hope in sharing all these essays? I mean, again, I will reiterate, I love the fact that it is a compilation of both personal and professional stories. And I'm wondering if you have a takeaway that you are hoping for a reader who gets this book.
I wanted to humanize medicine. I wanted the readers to come away with understanding that doctors have the same problems that they do in life and are dealing with some of the same things. And especially in our busy, hurried world when everything seems so fast, the office visits seem so quick, and electronic medical records have taken over, and your doctor's just sitting there typing away and not looking at you. I wanted to humanize medicine that way. And I also wanted to show the resilience of the human spirit by some of the stories of these really incredible patients, how heroic they are. We all, if we haven't already, it's a very rare person that isn't going to in the future have to deal with some illness or some devastating condition, whether it's addiction in a family member or neurodegenerative disease. And it's how we handle it that matters. We can't always cure, but compassion goes a long way towards healing. And healing and cure are not the same thing. And just the fact that we need to have compassion for our fellow man and not judge them. There's a lot of stigma with certain diseases too, and I think the stigma gets in the way of treating disease well. For instance, with addiction and with medical gaslighting, the stigma of the woman coming in for the third time complaining of the same thing. And the patient is not at fault, but you need to have a certain compassion to be able to figure out what's really going on. But more for the patients, I want the patients to come away understanding that they can advocate more for themselves. And if you don't feel that something is right, or you don't feel that you were listened to, that it's okay to get a second opinion.
Yeah.
And patients have intuition too, and they need to listen to themselves. And, something just doesn't feel right here. I don't feel like I was listened to. And the doctor might have been having a bad day.
Yeah.
And they might have not had the time for the 5 problems you brought them that day. They might have only had time for 1 and deal with that one effectively. And that's okay. Maybe you need to go back and deal with the other one, in more length.
Well, like so many things, all of these things take patience and time, and it's exemplified in so much of what you've written about. My final question is always the daring one. What was most daring about this book for you?
Well, I didn't think of myself as a writer. So I was putting myself out I'm a physician. I don't think of myself as a writer. So I'm putting myself out as a writer. And I don't have the master's in fine arts. I wasn't an English major. I haven't been writing all my life. And I was just really hoping that I could make this a literary exercise and bring that vivid imagery to the patient, not the patient here, I'm talking about patients. I can't switch back and forth to the reader so that they felt like they were in my pocket in the room with the patient and seeing what it's like to be a neurologist. I had a hard time with that. And I also had a hard time with the personal stories because it's a memoir and they have to be absolutely true. And, putting yourself out there a little bit is always a difficult thing with memoir.
Absolutely.
So I have a couple of personal stories in here that were hard. They were hard to write down, but I felt that they intimately connected with neurologic disease, and they connected me to the stories and how I evolved as a human being over the years, and how some of the things that I lived through in a way made me a more compassionate physician dealing with not only the patients, but their families.
Yeah. Yeah. Thank you so much. Are you doing any more writing?
I'm writing more short stories, true medical stories. and publishing them in individual places, literary reviews and some online. And I don't know if I'll compile them into a full book again. I might. I also have another book I'm writing about addiction and the fact that addiction is a brain disease and it's too often stigmatized.
Yeah.
And I touch on that a little bit in this book with a couple of essays, but I feel very strongly as a neurologist and someone who's dealt with addiction in my own family that it's not recognized for the brain disease that it is.
Yeah.
And I want to write something that really speaks to that.
And that essay, you speak very eloquently and very passionately. I sort of felt that before, but the way you describe it, it was very well articulated.
Thank you. My addiction story, The Thief.
Yeah, The Thief. Thank you. I was blanking on the title of it, but The Thief. I mean, that just was really like,
it's like a thief in the night that just comes in, and it's most often a young individual. When they get addicted, they're usually young, that gets in the child's brain, and you don't even know as a parent it's happening.
Right. Well, thank you. I wish we had time for all of them, but I really appreciate your time today.
Thank you so much for giving me this opportunity.
Wow. What a fascinating conversation. I love hearing medical stories. It is just endlessly fascinating to me to hear more about the interplay, as she was saying, about our consciousness and subconsciousness, how the physiological and the psychological are interconnected, and conversion disorders. That was a new term to me, something that is not within the patient's consciousness to control. That's something that warrants a bit more digging, I think. Another big takeaway from this highly accomplished and highly sensitive doctor: the power of journaling. Take those difficult experiences and pour them out of you onto the page. It's the first step in integrating and processing the stuff in life we have trouble making sense of. After the fact, just to give you a little more about Carolyn Larkin Taylor, she received the Humaneness in Medicine Award from the Philadelphia Medical Society and was named one of Philadelphia Magazine's top doctors for women. In 2001, she moved to the Pacific Northwest, where she lives today, where she founded Northwest Neurology and the Cascadia Center for Multiple Sclerosis. Throughout her journey, she has been a passionate advocate for MS patients and is dedicated to educating others about addiction as a brain disease, as she was saying right at the end there. That essay she mentions, The Thief, is fascinating. I really encourage you to get this book for that, if nothing else. There is a link in the show notes to purchase her book, Whispers of the Mind, a Neurologist Memoir. Since you made it this far into the podcast, a very important thing for me to bring to the forefront of your consciousness is to follow this podcast so that it will automatically pop into your queue on the first Thursday of every month. Yes, this month it was a little late because of New Year's, but usually the first Thursday of every month. I do this podcast because I love hearing writers read their own writing. And if you might also rate or give a quick review, it'll help other listeners to find it as well. Also, you can sign up for my free monthly newsletter. It is called The Redo, where I mull over topics and tangents from these conversations I have with writers. You can sign up for that at my website, michellerado.com. Again, my thanks to Dr. Carolyn Larkin Taylor for this conversation. Thanks to my husband, Phil Rado, the singer and songwriter of all the music that starts and ends this podcast. Most of all, my thanks to you for daring to listen. I'll catch you next time.
And nothing's gonna break my fall. There's nothing in the protocol. It's like swimming up waterfall or taking away the ground. Taking away the It's like taking away the ground